everyone, this is Suprabha. Welcome back to another session with me. In today's session, we will be discussing about vesicoureteral reflux. Well, vesicoureteral reflux occurs when the urine in the bladder flows back to the ureters and the kidneys. So that means here the urine is having backflow. So there is backflow of urine to the ureters and to the kidneys. So you can understand that if there is backflow of urine, that means the waste products are not getting excreted from the body, right? So that also means that the waste products are getting back to the ureters and the kidneys. So what will happen? The kidney will be at risk. So there would be recurrent infection of the kidneys. And when there is recurrent infection, there is a chance that the kidney would get damaged eventually. So over time, what would happen? There would be scar formation over the kidneys and the kidney would get damaged eventually. So normally what happens, the long submucosal and the intravascular segment of the ureter at the uretrovesical junction closes when the bladder contracts, and that is how it prevents the backflow of the urine. So once the bladder contracts, this segment closes off, and that is how, because of that, the urine cannot go back to the ureters and to the kidneys back from the bladder. So we can say that is how this reflux is prevented, or vesicoureteral reflux is prevented. So let us move on to the meaning of vesicoureteral reflux. So it is an abnormal retrograde flow of bladder urine into the ureters. So here what we can see is that there is abnormal retrograde flow, right? Now normally what happens is that the urine travels from the kidneys via the ureters to the bladder. That is what is the normal passage for the urine. So through that pathway the urine travels. But here in vesicoureteral reflux, the pathway is reversed, or the passage is reversed. So here there will be flow of urine, but the direction of flow of urine would be reversed. So vesicoureteral reflux may present before birth also. Now it might be present as prenatal hydronephrosis or an abnormal widening of the ureter, or with a UTI or acute pyelonephritis, and it is mostly associated with recurrent urinary tract infection. Next, moving on to the clinical manifestations. So newborns who have vesicoureteral reflux, they might be lethargic, or they might have delayed growth, and also they might have urinary tract infection. But in case if they have urinary tract infection, in that case they will have certain symptoms. So if the child is having urinary tract infection, he may have pyrexia, or he may have dysuria or frequent urination. Also, there might be malodorous urine, chills, vomiting, and apart from these things, the child may also have incontinence of urine. Well, next let us move on to the classification of vesicoureteral reflux, or VUR. So majorly here we have two types of VUR, that is primary VUR and secondary VUR. So first let us talk about the primary vesicoureteral reflux. Now this is present at birth, and it is caused by a defect in the development of the valve at the end of the ureter. So as we already discussed earlier, that how this vesicoureteral reflux is prevented, right? So once the bladder contracts, the valve which is present in the uretrovesical junction, it closes off, and that is how it is prevented. So here clearly we can see in the primary vesicoureteral reflux that there is this valve is not properly formed or developed, so it won't be able to close off properly, and that's the reason the urine would backflow to the ureter and to the kidneys back from the bladder. So among these two types, that is primary VUR and secondary VUR, this primary VUR is the most common type of vesicoureteral reflux, and it is mostly, it is diagnosed shortly after birth. And the next one is secondary VUR, or secondary vesicoureteral reflux. So this occurs when there is an obstruction in the bladder or urethra which causes the urine to backflow to the kidneys. Now, this might occur at any age or because of several reasons. Now, as we saw that the primary VUR would mostly, it would be detected shortly after birth, but secondary VUR is not like that. So, it can happen at any age. And also, there might be several reasons for behind this secondary VUR. Now, this might be caused by surgery or if there is any sort of injury, and also if there is a pattern of emptying the bladder which is not normal, or if there is any past infection which has put significant amount of pressure on the bladder, and because of that the urine is not able to flow on its usual path. So that is the reason there is backflow of urine from the bladder back to the ureters and the kidneys. So that might be a cause of vesicoureteral reflux. And apart from these things, this is also common when in children who has other birth defects. For example, the child who has spina bifida has more risk of having vesicoureteral reflux. Now, the severity of this condition depends upon how far the urine backs up and how wide the ureter is. So that is how we would get to know that, even if there is any obstruction, how severe it is. So to understand the severity of this condition, we have grades. Now, let us move on to the grades of vesicoureteral reflux. So first we have grade 1, where there would be reflux into non-dilated ureter. So that means the ureter is not dilated and it's not wide enough. So it is there is reflux, but there is reflux of urine into a non-dilated ureter. Next is grade 2. In grade 2 also we cannot see any sort of dilatation. So there would be no dilatation, but there would be reflux of urine into the renal pelvis and also the renal calyces. The next one is grade 3. So here we can see mild to moderate dilatation of the ureter, of the renal pelvis and renal calyces with minimal blunting of the fornices. So this is what we can see in grade 3. And then there is grade 4. So in grade 4, we can see dilatation of the renal pelvis and calyces with moderate ureteral tortuosity. And the last one is grade 5. So here we can see gross dilatation of the ureter, pelvis and calyces, ureteral tortuosity, loss of papillary impressions. So clearly from the grades you can understand that how high the grades will be, the condition will also be that severe. So next let us move on to the diagnostic evaluation of vesicoureteral reflux. So for diagnostic evaluation, first we would do history collection and physical examination. And then we can do nuclear cystogram and also ultrasonic cystography and abdominal ultrasound. So ultrasound we can do to detect the size and shape of the kidneys, but that won't detect the reflux definitely. So after that we can also do urine culture, so to understand if there is urinary tract infection. Next, moving on to the management. So here in the management, there is spontaneous resolution of reflux is very common. So in most of the cases we can see there would be spontaneous resolution. But in case if there is high grade reflux, then it is less likely to resolve spontaneously. So it needs surgical correction or medical management. So first let us talk about the medical management. So here there will be extended use of prophylactic antibiotics. So if the child is less than 2 months old, then the child will be given with amoxicillin, and if the child is more than 2 months old, in that case the child will be given with cotrimoxazole. Next is surgical modalities. So in surgical modalities, we have endoscopic management and then we have ureteric reimplantation. So in endoscopic management, they basically inject a substance into the area where the ureter meets the bladder to prevent the backflow of the urine. And in ureteral reimplantation, the connection between the ureter and the bladder is corrected so that the urine can flow normally from the ureter to the bladder. So that is how it is treated. Well, so this was all about vesicoureteral reflux. I hope you have got a better insight about the topic. Thank you.